So I'm Scott Podolsky, and I want to welcome everyone back to the Department of Global Health and Social Medicine seminar series. We're getting extremely proud to be able to host the MMSc Alumni in Action Talks. And I get the honor of introducing the program director of the Master of Medical Sciences in Global Health Delivery program, Dr. Joya Mukherjee. Dr. Mukherjee, as I suspect most everyone here knows, is Associate Professor of Global Health and Social Medicine at Harvard Medical School and Associate Professor of Medicine in the Division of Global Health Equity in the Department of Medicine at the Brigham and Women's Hospital. She teaches infectious disease, global health delivery, and human rights to health professionals and students from around the world, and she'll have the opportunity of introducing our esteemed speakers today. They're going to then speak, and then we can do questions and answers after that, which you can submit through the Q&A function. So I'll hand this over to Joya.
Welcome, everybody, and thank you, Scott. And as you can see, I'm in my non-business casual. I'm heading out on a bike ride, but of course, I couldn't miss my good friend, Archie George Ayeh. So Archie was in our Master's in Global Health Delivery Master's program in 2017, class of 2017, which already feels like a long time ago, pre-COVID. But also, Archie and I have been friends since about 2006 or 2007. I was trying to remember, Arch, when he was started working as an operations person in our Partners in Health project in Lesotho and became the deputy director and program director of that program before joining the Masters. What I think is really fascinating is that Archie also got an MBA before coming to our program and was always very interested in innovative financing and had worked with the government of Lesotho on some of the innovative financing around health reform, studied the work of village health workers as his master's program, and then moving home to his native Ghana, formed FastCare Clinic with colleagues that we're going to hear from today, including Nii Nortey Hanson and also Martinson Obeng-Agyei from Vodafone and from FastCare Clinic. And they're going to really talk about how they've leveraged something so interesting, which is about not only cell phones, but cell phone payment system that people make to do sort of financing and really break down some of the barriers of access for people to achieve primary care. So I'm really excited to hear from Archie. This is a very innovative program and something that I know that was always knocking around Archie's brain for many years. So I'll turn it over to you, Archie, and welcome to Dr. Nortey and Mr. Agyei. We're just thrilled to have all of you with us today.
Thank you very much, Joya, for your kind words. Indeed, Joya and I go way back from 2006, and we've been doing some good things together for a long time. So FastCare Clinic started in 2018 when I returned to Ghana late 2017. We were in the process of setting up a cardiovascular center in Ghana, but then they hadn't factored in the pathways of care for the low income and vulnerable populations. So I took it upon myself to find out how the case finding plan in place for them and how to be able to access the facility, which happened to be quite an affluent neighborhood in Accra. I was a little taken aback when I realized that in the midst of many health facilities in Accra, many of the dwellers in the low-income neighborhoods and communities do not have access. It's quite a difficult process for them gaining access to these facilities. So then the whole idea of setting up clinics that will create a platform for them to be referred to these facilities, to the well-established facilities, began. That's where it began really evolving. So I abandoned my interest in the hospital and focus more on providing care, how to provide care to the communities. But then being a private intervention needed money. So I had to innovate a way of getting the community to getting them involved in the process. So we had an extensive engagement with the community association. It was quite interesting to note that the communities had formed groups, support groups for themselves, different kinds of groups, from petty traders, from the normal dwellers, and in an umbrella group called Slum Dwellers Association. And the other thing that was working against these people, or is working against them, is that most of them are classified non-formal, especially in their businesses. Their businesses are so small. Most of them are not registered. They do not have access to banks and all that. So it kind of works against them when it comes to access to finance and so many other things that are needed to make businesses grow. So they are perpetually caught in this cycle where even though they are public facilities or there are hospitals or at banks around, it's hard for them to tap into it. So we modeled and did some calculations and realized that if they all could contribute barest minimum of amount of money and we work on the volumes, we will be able to provide extensive primary health care that would now serve as a platform to create proper pathways for them into the conventional or traditional conventional medicine that existed in Ghana. I was also very surprised to know that less than 1.1% of the Ghanaian population could afford to spend 10% of their income, of their total household income on healthcare. So it was very, very necessary to get a model that would take the barest minimum from the community dwellers, from these low income people. The need was so extensive, but we figured we had to start from somewhere. Just in Accra, there are about 1.5 million homes that make up massive urban slums. And we had 500,000 as our target based on where we were starting from. And we realized that 400,000 had unmet healthcare needs. And what they do is that they resort to peddlers of drugs in wheelbarrows in the marketplaces and in the slums, who sell drugs with unproven efficacy to them. And then the health-seeking behavior is so poor that they live with very, very dangerous conditions for a very long time till it is at a critical stage, and then they are rushed into hospitals. Then we targeted the first 100,000 people within the first 5 years and started with 10,000 people, an area where we could get 10,000 people to start with, so that those volumes will be manageable, we'll be able to meet our needs and then provide them the necessary care. But the barriers to care are still the same for these people. It's still geographic. Even though there are many hospitals around, where the hospitals are do not favor the slum dwellers. Two, because of the nature of the work they do, they are daily income earners. So leaving their trade and going to the hospital, which would take a whole day if they're accessing public hospital services, it would take them a whole day to get treatment for simple ailments. So one, they're going to lose income, and two, they are going to pay for it. So it's like a double income loss for them. So they tend to stick around for a long time until they can no longer, they are completely immobilized before they seek care. And then psychologically, there is always the burden of the anxiety when you go to these facilities, the way they are treated in the public hospitals, they are talked down to like very little dignity for them, tends to make it not attractive for them And then what I also realized that even though there's a national health insurance scheme, there's always some amount of money they need to pay out of pocket. And the anxiety of not knowing how much they're going to pay and the embarrassment of it makes them stay away completely. So then we decided that first of all, we're going to build very small clinics that we could manage, but would do the job for us. We considered mobile clinics, but what the community told us was that they don't have confidence in mobile clinics simply because they see it as an ad hoc service delivery. They come in, they don't take their records, so there's no medical records for them. They just come in, do few things, takes loads of pictures and go away for their own interest. So they don't have much confidence in that. So we had to come up with a model where we'll have a small clinic, very small, but we'll be able to have a 2-bed recovery room, 2 consulting rooms, pharmacy, and a diagnostics room. And we're able to put that up. But now the question now was of how were they going to pay for services? So from our analysis, we realized that paying approximately 10 cents a day, which most of them are 10 US cents a day in Ghana cedis equivalent, they would be able to, we will be able to cover the cost and then give them the necessary care that is needed. So we created something from our partners in health experience. I created some sort of village health workers for them who would then go around, identify cases and collect their daily contributions, which broken down is manageable for them to pay. But then the human challenge in collecting this money was very, very difficult. It nearly collapsed the whole project. And I think that's when Vodafone came in, and I will elaborate more on it when as we go on. So we moved on to we designed a whole structure of how we want the project to expand. The first idea was to create these small satellite clinics while we increase our subscriber base, the numbers. And then instead of having individual laboratory and diagnostic centers in these clinics, we decided to have just one laboratory for every 4 clinics. In this case, we then reduce the cost in operating them, reduce the downtime for idle laboratory equipment, and then utilize sample transportation motorbikes to move them to the center, and then use technology to send the results back to the clinics which are in the communities. And this helped exponentially to reduce our operational costs when it comes to diagnostics and lab works. And then we realized that, and I think the doctor would speak more to that, even though we entered as primary healthcare, we became the face of healthcare in the communities. So we were going over and above the diseases we were supposed to treat, and some even need hospitalization. So we then decided to have inpatient care centers, not full-blown hospital, but enough to hold some of these patients overnight as they undergo treatment. And those then would move from the clinics into these centers. And then eventually we intend to have our own 100-bed hospital, 100-bed referral hospital. Because what we realize now is that when most of the people we have taken care of are referred to the hospital for more specialized care, they don't like going because the treatment they get from our facilities is way different from what they get when you go to the public facilities, or even some of the bigger private facilities. And so we have to now, it takes a long time to convince them and to accompany them to get these works done. So it's become a prominent objective of ours to have our own 100-bed referral hospital to complete the continuum of care for our subscribers and the community. So like I explained earlier, our model is 10 cents a day, and then the patient receives full primary healthcare, consultation, diagnosis, everything. But like I said earlier, we do more than that. We also support them with the chronic care. We didn't realize there was a lot of diabetic cases amongst low-income people in Ghana. We always thought it was a disease for the affluent in the society. But we've identified that it's about 50-50 proportion of people in low-income earners and high-income earners are all affected by diabetes. We also see a lot of cardiovascular problems. So all these things have become added on challenges or services that we had to add on to provide to the communities. And then we also provide them with ambulance services when the need arises to refer them for much superior care. So I will leave this slide for Martinson to explain to you how we had to go to Vodafone to help us overcome our challenges of the cash collection. The manual collection wasn't working for us. There were instances where people would collect their money and they won't bring the money. There were instances they will collect and they will tell you it was raining and you check there was no rain there. And so now the stories were numerous and it was getting really, really frustrating. And so Vodafone came in and intervened, and Martinson, who is the CEO, was very instrumental in working with Vodafone. And by the way, Vodafone is a mobile telecom operator in Ghana, is one of the two prominent ones here. And they have a cash payment system, electronic cash payment system, which is very, very popular among low-income earners because most of them do not have access to the traditional banking system. So he came in with that technology to support us, and it has been a huge break for us. So Martinson, you can take over from this slide, and then we continue with Dr. Nortey.
Thank you. Thank you, George. So at the point when we had the discussion with George, there was clearly a problem that needed to be solved. And the good thing is that for Vodafone as well, we do a lot of brand activities or association with healthcare. So we have a very popular health series that runs on TV called Healthline, where we actually go into the community and support people who have various disease and complications. We take them through the hospital process and then we pay for them to go home. We actually have a very popular one as well that we do on Mother's Day, where we go to the hospital and discharge all the patients who have been there who could not afford their bills for free. So when George brought this idea up of partnering them, it was actually in line with the Vodafone way of doing things and in line with our purpose as an organization. So we have the Vodafone Foundation as well that does that, plus the Healthline. Now, like George mentioned, digitizing the payment ecosystem is a very important part of what we do because we are driving financial inclusion. And the whole agenda is to try and get the people who are not within the banking, the formal banking system, to be able to transact and do business on the mobile money platform. And the main actors are access, affordability, and then availability for us. So when I went to the hospital and I saw the area that they were operating, we saw that they were low-income earners. The price had been determined, commuting in and out every day to come and pay what was due the hospital just so that they could access healthcare when they needed it the most was a challenge. So what we did was to set up an integration with FastCare Clinics that now allowed them, their system and our system, to interface. Once the two systems were talking through an API connection, we made that the service available on our mobile money platform. So if you go on our mobile money platform and you dial *110#, you can actually go through a process and you see FastCare there, and then you can pay on a daily basis. We also have an auto deduct that allows the deduction to be done as long as the customer has money within their wallet. So what does it really mean for the support we want to provide for healthcare? One, transaction costs are reduced or eliminated. So here, you realize that the actual cost of transaction will come down once you take away all the commuting and transportation and everything. Reconciliation and reporting doesn't become an issue again for George and the clinic staff because they all have access to a graphical user interface that allows them to be able to identify who has paid, see how many transactions were done in a day, how many came in a week, what times the people are doing the transaction, and building some level of data to be able to ascertain what the customers, when and where the customers are actually paying for. Once there's the elimination of cash, you remember during the COVID period, one of the things we tried to do was to encourage customers from, discourage customers from using physical cash because the disease was also transferable through any means because we didn't know everything. And if you look at the demographics of the people that FastCare Clinic targets, these are mainly daily manual labor workers who work hustle and bustle in the streets of Accra, and exchanging monies happens at various stages of their daily cycle. So we wanted to eliminate that as well. So once cashless was a thing to go, they also came to agree that if you pay this using Vodafone cash, then you don't have to deal with cash. That helps us to reduce the COVID-19 spread as well. Theft was also eliminated because once the money is on your phone, nobody can have access to it but yourself. And then obviously eliminating the case where George's genuine people will not have access to their funds when they go collect physically because somebody would have come there, posed as the collection agent, and then made away with the money. On the fraud side as well, when George and his team sit in the office, his finance guy can look at how much has come in, who has paid, who hasn't paid, and therefore there was elimination completely of any form of fraud. Big data analytics comes into the picture because we're able to get all forms of data, different types of data from the demographics, showing the timestamp is registered, when they were doing it, how many females are paying, how many males are paying, and all of that. So it gives us very good information that the hospital can use to do its future planning. And then the digital platform system allows for targeted marketing. So what we do today is that there are days when we send the SMS blast to customers within what we call the controlled vicinity. So all the people who fall within George's target in and around the hospital, this information is sent out to them. And on days when we do that and encourage people to do that, he himself gets inundated with the number of calls that come in, whilst people who really need the service also get to sign on because they learn about the availability. How does this work? Very, very simple. Any customer who is on Vodafone today can register for Vodafone Cash. It's a simple USSD *110 hash. So you don't need any complexity of a phone. You don't need a smartphone actually to be able to do this. You need a regular feature phone or even less than a feature phone, very, very basic phone that can dial the short code. And then you're good to go. So that eliminates any form of complexity for the target audience. And out of that, you can see we have all the branches that are linked to this service can have access to see. So once you enter the hospital, you mention your name or they take your card, they can immediately tell from the system if you have paid your premium and therefore you are entitled to the healthcare. So in a nutshell, we are just very happy about the partnership and poised to use technology to support this initiative, which is actually novel in this country because nobody is giving this kind of service. So we are happy to partner with FastCare, and there's many things we want to do going forward with them. So George, I'll hand over to you at this point.
Thank you very much, Matt. So 2 years later, we have served 21,000 patients so far. These are the numbers we have. We have 12,000 subscribers so far, with 7,000 active subscribers. Some pay for a period, they stop, and then they restart again. But there are some people who have been very, very active and consistent with their payments. We finding a way to reward those who have stayed with us for all this period. and move it up from there and see what we can do for them to keep them happy. And then we have 2 clinics and a third one about to open up, and in an estimated catchment population of 200,000 people. We've also formed very strong partnerships with the National TB Program. We work with them to identify MDR TB patients in their communities. And yes, of course, we have the Vodafone. We have the Slum Dwellers Association, who actually lead us to the other slums where our services are needed the most. So they actually drive our expansion, our expansion model. They actually drive it for us. We also have a new partnership with an organization called People's Pension Trust. And what they do is that most of these slum dwellers do not have pension or do not have any means of having pension. So they have come in to provide some pension scheme for them. And so they wrap their services around our healthcare service and form one package for them. And then they're able to provide them with their pensions. And it also provides them some form of disability fund for when they get injured and they are not able to work, or they are immobilized by diseases and they can't move, then they'll be able to step in and give them some money. So it's FastCare is gradually creating a form of safety net for these low-income people who have been largely ignored from all the formal sector services, safety net services that are provided. So far we have our accreditation with the Health Facilities Regulatory Authority, and we are part of the private health associations, and we're seeking to do more with other agencies, government agencies who need us, like district assemblies and the disaster management organization, National Disaster Management Organization, as we happen to be the most disaster prone areas. So the conversations are ongoing to represent them in these areas as well. We are, this was our very first patient. When we opened our clinic, this little girl got injured around the community. She was rushed in, so we keep her picture to remind us of where we're coming from. And at this stage, I'll leave it for Dr. Hanson Nortey, who handles all our medical issues, to take over from there.
Thank you very much, George, for the opportunity. So within our catchment area of our service delivery, we have assessed what are the service opportunities we have. Apart from providing basic clinical care services, which are structured, tailored to the primary healthcare level, we believe that there are opportunities for minor surgeries, and our first case actually opened up our eyes to the fact that yes, there are big opportunities for doing a lot of minor surgeries, and if we could improve on our capacity, we could actually take advantage of some of these services. We provide emergency services, we provide chronic care for persons within various age brackets, including the aged. We have opportunities for geriatric care. And then most importantly, we have opportunity for home-based care, because there are quite a number of people who are literally stuck in their homes, in the communities. And because of certain forms of disability, or maybe even because of financial inaccessibility, they do not seek to walk into a health facility, no matter how close the health facility is to them. In delivering our care services, we have looked at the various scopes available to us. So we looked at what scope of treatments opportunities do we have? Okay, doing a simple analysis of our catchment area and our service delivery. We see that we have opportunities to do routine services, provide routine services, malaria, diarrhea, upper respiratory tract treatment. These are the basic things that most clients will walk into the facility for. And then we also saw that because it's a densely populated community, services, antenatal care services are needed. And so we have provided ultrasound services for antenatal care. Where trauma is a big deal. We have been doing TB screening as well. We have added on HIV and hepatitis B screening, and then also chronic care for the non-communicable diseases. From this, these services and areas of service delivery, we have seen that we have been able to identify our niche of clients. For us, these slum dwellers who have limited access to health services see us as the biggest opportunity for health service delivery in their lives. And so they happily access services within our facilities. We offer free screening for our clients. We realize that, yes, because this is a form of insurance, definitely some people will not access services by the end of the year. So as part of the plan to reward, like George talked about, we have introduced a simple system of offering free screening for anybody who hasn't used their services. You subscribe or use up the services after subscription. Every quarter we have opened up for free screening. And then also we have now introduced community-based screening services. So we not just stay in the facility, but periodically we also go into the community. We are happy to say that we're not too far from two major markets in Accra. And so we are able to walk into or organize the market women and then the stakeholders within the market to be able to do periodic health screening for them. What impact have we made? We believe that our model has introduced easy access to primary healthcare services within these communities that would not really have had access to primary healthcare. They have now an assured access to health services because of the low cost, and because we have removed the barrier of financial inaccessibility. And then realistically, the low cost health services is a plus for us. So they are not afraid to walk into our facility because they know that definitely our cost is not too high. We also, in addition to all this, have given them an opportunity to change their health-seeking behavior. And so now there's no fear of accessing health services. What are further requirements? I mean, looking into the future, what do we believe is the way forward for us? One major hurdle we have been able to cross with removing the human interface for collections using a mobile money system. And so, yes, Vodafone has really been a big blessing to us to be able to improve on our collections and subscriptions. Then in addition to that, we are looking at improving on our infrastructure and improving access on our number of our facilities. Looking at the model that George showed earlier, we believe we should be able to increase the numbers of facilities. We're looking at all forms of opportunities for investment to increase and to scale up the model, because we believe this is an excellent model that will do well within the low cost, low income communities. And so a lot of investments, we are seeking a lot of investment to be able to scale up our model across the city. What are some of the main challenges we have? Yes, poor health-seeking behavior is a real big deal amongst the communities we work with. People will just not walk into a health facility. Even at this low-cost model, there are lots of people who still would not be willing to walk into a health facility. Sometimes it's a psychological feeling that once you go into a health facility, then you are weak, especially among the male population. And so we are, as part of our community access, community activities that we do, we are seeking to interact with the stakeholders and the community leaders, to the population in the communities on access with capital for expansion. And in our part of the world, capital is very expensive. And so it becomes difficult to access funding to be able to expand on even good investment opportunities. Human resource is a challenge because ours is a low-cost model. Of course, our incomes are not astronomical. We are really just breaking even. I mean, for now, we're just breaking even in terms of meeting the cost of our service delivery. And so it is very difficult to be able to recruit high-end human resource related to the nursing staff, the laboratory staff, the pharmacy staff, and even the clinicians. So sometimes, I mean, I provide care services periodically. We have a physician assistant who is there. And so we alternate and we provide the care services. It's quite expensive because the human resource, government seems to be the biggest, or government is actually the biggest recruiter, employer of health providers in Ghana. And immediately government calls for recruitment, everybody runs to secure government employment because that is more secure. And then we have some regulatory red tape that we have to deal with, of course. We do not shy away from being regulated. As a health facility, we believe we must be regulated. But there are just too many stumbling blocks within the regulatory process. So it's been quite challenging to overcome all these regulatory red tapes. But 2 years down the line, we have done well, and we are almost there with some of the regulatory issues. But however, we are actually delivering the services within the communities. So what's the future? I think I'll hand over. Okay. So the future for us, like we showed in the model, is to come up with a really equipped central laboratory system where we can actually send all our samples from our network of facilities to deliver specialized laboratory support services from one location, properly accredited, properly regulated, so that we know we are providing top-notch service delivery. We're looking at developing a 100-bed hospital facility to take care of the numerous referrals as they come up. We definitely do not want to lose our clients as we gain them. We're also looking at centralized pharmacy system for logistics procurement, so that we're able to ensure continuous flow of commodities and logistics for service delivery. We seek to expand to other regions in the country because Greater Accra is not the only region where slum dwellers and low-income populations exist. And we're hoping to even improve on the capacity of our staff, because we believe that continuous professional development is the real deal that would make sure that our staff are able to deliver quality health services. And then finally, we're hoping that over time, with technology coming on board and the lessons learned from COVID-19, we'll be able to provide telemedicine to some of our clients. Thank you very much. And I'll hand over to George to give a few final words.
Yes, to drum on what Dr. Nortey was saying about changing health-seeking behavior, it's not just altruistic, but it's also economical, because what happens is we realize that because they stay with their disease for so long, when they come into the facility when they are really, really ill, it becomes more expensive to take care of them. It becomes more difficult to have treatment success and all. So we are better off encouraging them using the services and detecting diseases at an early stage at the primary healthcare level before it becomes a big problem that would impact even the treatment outcomes. So we do a lot of community programs. We go there, try to screen to identify cases. It's all part of the model. And that's why, unlike the formal insurance companies where you are penalized for using the services, we actually reward you for using the services more, because then it makes it manageable for us. So that is FastCare so far, 2 years down the line. And I think that brings us to the end of our presentation, and we are open now for discussions, questions, advice, and anything else that you have for us and Vodafone. Thank you very much.
Thank you so much, George and Nii and Martinson. I think Joya may not be here now, so I'm happy to help moderate. Again, thank you very much. There are a few questions, so I'll start off with some of those questions. Jude Beauchamp writes, "Thank you, Archie and team. Fantastic initiative. Kudos to you. 10 cents per day is nothing for most of us, for sure. I'm sure FastCare made a lot of sacrifice keeping the price as low as possible for those in need. However, I was wondering, what is the plan for those, the poorest, who might still not be able to pay in any government or third-party subsidies to help reach the poorest that are in great need of the services you provide?"
Let me take up that question. In Ghana, we have a model for a health insurance model as a country that ensures that the lowest or the poorest of the poor get access. Unfortunately, it is still not accessible. And so government has even put in place some measures there's an intervention called the Livelihood Empowerment for Poor, LEAP. And that tries to give handouts, monthly pocket money to the very poor, poorest of the poor. Unfortunately, they are more interested in using some of these support systems to get food rather than invest in health. And so we're looking at the possibility of joining forces with the local assembly in the areas where we work to see whether then the local assembly can automatically enroll these people on our model. Because really, of course, there needs to be some commitment for payment. And so for now, because of the costs related to our service and because of what we have, because we haven't grown enough reserves to be able to take on people for free, this is the best model we are willing to offer for now. Thank you. Hope the question is properly answered.
Thanks. It does raise a question. So to someone relatively ignorant like myself who looks online and it sounds as though Ghana has a somewhat robust national health insurance program, but it sounds like a different story from what you're telling us. Can you tell us sort of, I guess, the background, your own thoughts on the Ghanaian national health insurance program and perhaps its limitations?
Yeah, I must confess that, yes, from outside, it looks like Ghana has a real robust and excellent health insurance scheme. But the reality is that our health insurance scheme has really not been the very best as we all anticipated it to be. In terms of structures and plan, it is actually designed to be a very excellent scheme, but the implementation has not yielded what was really anticipated. Even as at now, the best coverage we've had at any point in time is about 65% of active membership membership from the population. So really, it hasn't been an excellent model for us. And the cost of subscription has also been, unfortunately, higher than some people can easily afford. Now there's a new model to try to use health mobile money systems like we are doing for subscription, but it still does not come close to what we are doing because that system requests for a lump sum payment. The current lump sum payment, I think, is about $12. So it's still beyond the reach of quite a number of people.
Thank you. There are a number of questions coming in.
To add to that, most of the service, it takes such a long time for the service providers to be paid by the National Health Insurance. So most of the private service providers do not accept it. They do not accept it, or they accept it at some cost. They charge you more, and there's a lot of co-payment, out-of-pocket co-payment, which many people are not prepared for. So there's still that gap that needs to be ironed out with the National Health Insurance. And I think that is what has made our model work for the communities.
Thank you. Several questions coming in now. One was a very specific one. Is the 10 cents per day per individual or for the entire household?
So we have a family package, and we have individual, and we have periodic packages. So the 10 cents a day is for an individual, and then for a family or for a couple, it reduces. Instead of 20 cents, it comes to like 18, and for family of it comes to like 15, and for a family of 4, it is about 17 cents. It's 70. Like, we have those structured packages for family package, for periodic package, for those who want to pay weekly, for those who want to pay monthly. There are some little discounts that comes with it along the line, along the chain. Yeah.
Thank you. One question was, from a sustainability standpoint, beyond the actual financing mechanism that you mentioned, is there any element of grant funding available to you, or that you've sought?
We haven't had any grant funding yet. We will gladly welcome a grant funding with open arms. But what we're doing now is that we're trying to drive the volumes, the numbers of people. Once the volume, we reach that critical mass of the large volume, we'll be able then to move and expand and be in that comfortable zone. But for now, we will gladly welcome grant funding, because we need that funding to expand, to be able to attract more people. Like Vodafone is doing for us, able to give us a national coverage with their marketing, with their targeted advertising. But the problem is certain areas where our services are demanded, we will not be there. We will not have the infrastructure there to support those communities. We've had many of those where some communities are actually inviting us, the chiefs, the local groups are inviting us, but we are not able to go there because we don't have enough to expand our infrastructure to those areas. So for now, we are hoping, our numbers are growing, and we hope we'll get a critical number that will be able to help us expand and be more sustainable.
Thank you. And I'll keep going through these relatively in order. So Christina Lively, who you know well, wrote wonderful talk. Yeah. When Dr. Nortey mentioned, quote, poor health-seeking behavior, I wondered if you have any sense of why many people are reluctant to seek care. Thanks again for this talk. Christina.
Okay, so I think psychologically, there's a feeling, especially among the male population, that anyone who goes to hospital is weak. And so if you're sick, you should actually be able to somehow fight the disease with your body, because there's always the doubt about the germ theory of disease. Sometimes there's a lot of belief in superstition as part of disease causation. And so people would not readily accept germ theory, even in modern times, with all the knowledge that is available to us. So yes, unfortunately, health-seeking behavior of the average people living within some of these communities is extremely low.
And to add to that, he did mention superstition, which is a huge problem. The first result will usually be to seek a pastor to pray for them, or seek a traditional healer or priest. And then the next line will be using herbal concoctions and other things, with all the fancy theories about it, until the point where all these have failed or even made the situation worse. Then they begin to seek conventional medicine for as their mode of care. So it's always coming at the tail end. It's not the first option. It's not only for FastCare, it's for healthcare delivery across Ghana. We only come in at the tail end. So we are prone to getting some of the worst, sickest patients. Whether primary healthcare, whether secondary or tertiary care, you're always going to get it bad. So that is why we are focusing on getting our services ahead of pastors and traditionalists and magicians, and I call some of them magicians. Things like that before it even gets to us. So we want to push ourselves ahead of that curve, and then we'll be able to serve them much better.
Sure. Once there's effective remedies provided by you, then people will seek the effective remedies for sure. Terrence Marks asked about, this is a little different, but how you came more specifically to the 10 cents per day number, And do you see that increasing or decreasing? And how do you account for that moving forward?
So the 10 cents per day was not only a decision that we made purely economic. We also had to look at the affordability, the ability of the community to pay. In our truest sense of a real business, would have charged nearly 25 to 30 cents per person. But we have to look at affordability. We have to look at the national health insurance, what they are charging. We have to factor in so many things and then drive at a break-even point that would enable us to have a sustained project. So the key things we looked at was when we go into a community, because we were working with the community associations and groups, they pledged at least 1,000 members ready to sign on. So once they give us those numbers of 1,000 people, we're able to pay salaries, we're able to make sure medication is available. The capital cost of diagnostic equipment, hematology machine, chemistry analyzers, was a real cost to set up. The setup cost was a real thing. So once we have these things in place, we are then able to use the daily subscription to pay for salaries, for utilities, and all the other things, the daily supplies that are needed. We're able to cover that. And then as the numbers grow, we begin to then plow back to pay off some of our creditors, pay off all these other things. So this is how we arrive at the 10 cents per day to make sure that with 1,000 patients committed, we'll be able to then move on and then establish a facility there.
Okay, thank you. So I want to ask, how do you mitigate adverse selection where there's disproportionate numbers of infirmed high utilizers that strain the system? And along those lines, have you ever thought about implementing any types of co-pays?
We haven't thought about co-pay. And then secondly, we actually love the high utilizers. What they do for us is that they take the message back to the community to encourage more people to use the facility. Mind you, there's also the element of payment fatigue. When people pay and pay and pay, and they are not using the facility, they begin to question the necessity for it. But when they have or know people who are utilizing it and coming back and forth with stories of how they've been taken care of and how well they are, it encourages more people to sign up. It encourages those who are paying to pay with the hope of one day needing the service and utilizing it. So yes, we have some of those people, we know them by name. We occasionally call them, hey, are you still around? We haven't seen you in a month or two. Some people just come there to just pour their hearts out, which to me is good for their mental health. They come in and they have myriads of problems and it serves as a safe space for them to speak. So hey, come in and then talk to the doctor. And to us, it's good. So we haven't discouraged that yet. And I think that's what makes us different from the traditional or the formal insurance schemes where people like that are penalized or, by making them pay more with time. So for now, it's working well for us. So we haven't thought about penalizing them.
Great. So are medicines and labs fully covered?
Yes, they are fully covered.
And is there
some level of labs? There are certain labs that we can do in our facility, but then we pay for it when we refer it to an external. Because of our organizational structure, we have partnerships with some bigger laboratories who then charge us at the discount, like really high discounts, to process lab works that we don't have the capacity to do or the equipment to do. They do it for us, and we pay much less than the individual would pay if they had gone there themselves. So we also broker this discounts and use our leverage partnerships to do that for them. Because hey, we also bring them customers that increases their volumes and their operational efficacy wherever they are.
Is there a particular formulary for medications?
We have the standard.
I think Archie's frozen for a second, but hopefully they'll come back. Carol, are you there? Let's see if it's me or if it's Archie who's frozen.
It's not you, it's Archie.
Okay. All right, let's give Archie another 30 seconds here. So.
Some troubles.
All right. Well, given that it's 1 o'clock, I'll reach out to Archie and Nii and Martinson after the effect. But I want to thank them for a fantastic talk and for helping all us think through these types of innovations to make healthcare accessible. And the next Alumni in Action talk is with Ana Cristina Sedas on June 23rd at 12:15 p.m. And I want to thank everyone for joining us today. We'll see you in 2 weeks. Take care.